So we've got a few minutes, got about 10 minutes or so for questions. Firstly, anybody in the room have a question either for Shradha or Chitra? So I think this is for Shradha. Are you still there, Shradha?
Yes, I am.
So there's a question here. Conventional enterovirus PCR means in-house entero PCR. I'm assuming that's correct. Is that right?
Yes, that's correct. So yeah, for our patients that were in the conventional group, intravirus PCR was performed in-house in central laboratory. And then when we implemented the test, the BioFire has the intravirus in the panel.
And then there's a follow-up question where it says, bloody tap, oof, CSF. Did it give good discordant result? I think I understand the question.
Yeah, is that bloody tap off CSF if it's really bloody?
Yeah, maybe, yeah.
Maybe that's what they're suggesting. Look, we often would, I guess it's difficult, isn't it? When you've got really blood stains, we may get a negative result. And I guess that would have to be interpreted in the clinical context, because how much CSF have you got in a really blood-stained tap, particularly in pediatric patients? So, sometimes if they're very blood-stained, we'd often speak to the clinicians, and this would often be in pediatric patients. And if that was negative, we'd sort of suggest, maybe just, we can't, if you're just doing a PCR of blood, you may not necessarily have any CSF there, so that, just so that they interpret a negative result with caution. But we did have some blood-stained CSF in there in that analysis.
Yep, thanks. And Shradha, I was just interested from my point of view, you saw an increase in antibiotic use with the BioFire, but a decrease in acyclovir.
Yes.
I mean, what do you think is going on there? What's the psychology behind that? It's interesting, isn't it? But
yeah, it is. It's really interesting. It's really interesting, I think. And I guess, we're doing some clinician interviews, and hopefully we might get more information. But my suspicion is when you've got, when you see a patient, query meningitis, they've got abnormal cells, they're sick, if you've got, if you're doing an in-house testing and you've got, say, negative intro, negative HSV, the clinician will probably go, it's probably some sort of viral infection, and maybe more comfortable stopping antibiotics. But when you've got this panel that's got like 14 targets, they're all negative, and you've still got a sick patient in front of you, it probably is still another virus that's not in the panel, but maybe the clinicians don't feel comfortable with that decision thought. When you see so many, not detected in your test results, I'm guessing, that may be one of the factors. We're also just going to look at, those ones that had really high cephalosporin use, whether there was an alternative diagnosis that might, maybe there was something else like, I don't know, E. coli, sometimes these results can be skewed if you've got, a few cases of gram-negative osteomyelitis or that sort of stuff. So we just need to look at that in a little bit more detail.
Yep, great, thanks. So any questions for Chitra? I might kick off a question for you, Chitra. I'm obviously looking at all these different methods. I know you can't really conclude anything so far, but what's your sense is going to be the most workable solution? If at least just from a sort of, you've done all these assays in the lab, some of them are more familiar than others. What have you found easiest so far? And
I think
maybe come to the mic.
Sure. It's a bit of a loaded question because there's pros and cons to each of these. If we're looking at time and cost, microbrain seems like the best option. They are also trying to dive more into AMR detection as well. So once that's up and running, I think it's very promising. The only con I can think about for microbrain is that you need fresh blood. So you'd have to process the blood within 24 hours. Otherwise, if the blood's not fresh, it clogs up the filter and it doesn't do the depletion properly, and you might get your microbes stuck in there. I think the other thing I am putting my hope in is shotgun sequencing, because cost-wise, it's only around 50 to 150, depending on how much in-depth sequencing you want to do with shotgun sequencing. So it's very cheap. Because with the panels, you do need to spend quite a bit more, and it takes much longer. It could be more sensitive, but it's coming to 800 AUD per sample. So that, I think you just need to see, it's a case-by-case thing, and then you just need to see if there's something that's, the patient's sick, but you can't find anything, and if they're really immunocompromised, it could be something rare. would you go with the panel? What if the panel doesn't cover it? So then you have to do shotgun sequencing. So you just have to make a decision based on the case, I think.
And I don't think you presented it, but you have looked at the bacterial recovery from microbrain samples.
Yeah.
Do you want to briefly describe what you found? Do you remember?
I'll try to remember. So I did do a little run with microbrain, but here I did push the limit, and usually they use 4 mils of whole blood, but I pushed it to 200 microliters into the filter, and then I just added more saline to pass everything through. So I did have a few dilutions. I had 10 to the 5 being the highest, 10 to the 3, then 2, 1. Obviously, we couldn't find anything E. coli in the lower ones. We did find it in 10 to the 5 with high confidence. The other thing we did note that, we did identify E. coli in the lower ones, but that was a huge background noise. So that's something I got introduced to. It's called the ketome. So the kits themselves come with their own contaminants, and that can really make, comprehending the results a bit difficult. So having a good bioinformatics team, a good set of positive controls, can really let you know what is true and what is noise. So that's something I learned from the microbrain.
It was interesting. I was in Taiwan a couple of weeks ago, and in fact, they're using these filters regularly. So patients with, obvious septic shock in the ED, they actually take the blood and push it through the filter almost at the bedside. So they do it sort of straight away. And they've been using it for several years, and they're kind of asking us why we're not doing it already. But anyway, that's the way things go. Good. All right. Well, look, we're at 1 o'clock, so we'll probably call it a day there. Thanks so much for everyone online, everybody in the building here, and thanks so much to our speakers here and remotely. And we will see you at the next CRE Respond meeting. Thank you.